Good afternoon, everyone. Welcome to this CME Nma Taraba. I'll be taking this topic briefly just to highlight the importance, the role of histopathology in clinical practice. This topic came about as a result of tissues when removed by clinicians, whether in private practice. Some clinicians still don't know the importance of submitting them for histopathological diagnosis. I'll be following this outline. Introduction, diagnostic tools, histopathology workflow, the importance or the role of histopathology in clinical practice, and then I'll briefly conclude. By way of introduction, histopathology is an important diagnostic tool used during a workup for various problems, including cancer. It's not only cancer, there are different other diagnoses that can be done with histopathology. It is generally recognized as the gold standard for the diagnosis of tumors, okay? And the pathologist and the clinicians usually play important roles in making this diagnosis. And in so doing, there must be a very good communication between the clinician and the histopathologist, okay? That is to say that if there's any report that the clinician is not understanding or requires some clarification, he should get back to the pathologist. You understand? And also the pathologist, in maybe filling of forms for the tissue submitted, if the pathologist seeks certain information, they will get back to the clinician and they can sort that out in order to make a precise diagnosis. Histopathology is the microscopic examination of diseased tissue, okay, in order to make a diagnosis, and it is the cornerstone of modern clinical practice. By analyzing tissue architecture, okay, and cellular structure, it provides the definitive diagnosis necessary to guide patient's care, okay, because it is said that and if you identify a problem, it is half solved. And so if you get the correct diagnosis for a particular disease, what it means is that you are likely to help your patient attain a cure, okay? It also helps determine disease severity and can tailor personalized treatment. The fundamental importance of histopathology in clinical practice, okay, are very many, and we'll see them in a short while, okay? These are the diagnostic tools that we use to make our diagnosis for the confirmatory diagnosis, okay? The first is histology. Like I said earlier, it is the mainstay for histopathological diagnosis of tissues that are removed, okay? And we have other diagnostic tools like the special stains, where they act as special techniques to the histology, because sometimes you find out that some diagnoses may require additional tools to actually confirm them. And so that is where the special techniques come. Special stains like the PAS, the GIMSA, the GROCOT, and all the rest, pair stains, oil red O, for lipids, and PET stains for iron, so many other stains. They are all assisting in, or rather supporting the histology. Okay, you have immunohistochemistry. This one is very important, is the use of antibodies, specific antibodies directed at antigens on tissues, okay, for the purpose of diagnosis. You have tissue culture. Some tissues can be cultured, you understand, to enable good consile diagnosis. You have flow cytometry, DNA microarray, electron microscopy. Of course, if you are doing your renal biopsy, of course, you can, apart from histology, you want to subject it to electron microscopy, okay? You have cytogenetics, DNA sequencing, molecular pathology or molecular biology, okay, where you want to do some of your genetic markers, okay, like your BRCA1, BRCA2, in order to find out if there's a familiar disposition of a patient, you understand, to cancer formation or to the development of cancer. And so if a family if a family tree has this predisposition, for instance, I just gave an example of BRCA1, BRCA2, okay, it means it can actually assist in preventing subsequent siblings from contacting, or rather from developing cancer of the breast. I just cited an example. Okay, these are the pathways with which we arrived at histopathological diagnosis. I call it the histopathological workflow. It starts with tissue collection as the clinicians collect the tissue. They send it to the histopathological lab, and it's usually put in a fixation, the formalin, 10% buffered formalin, and it's processed. In the process of processing, we usually pass it through we dehydrate the fluid in an ascending order of alcohol. We clear with xylene, and then we infiltrate with wax, and then embed the tissue. Okay, the next step is sectioning. After embedding in a tissue block, the tissue is sectioned. The internet connection is unstable. Okay, it's sectioned into thin slides, and then it is stained with the routine H&E stain, and then it is mounted with a cover slip, and then it is reviewed microscopically. This is where the histopathologist would look at the various patterns, various dispositions of the cells in order to arrive at a diagnosis, and then the interpretation of those viewing, and then finally it is reported, or rather translated into the diagnosis of the tissue. So let's look at some of the roles of histopathology in clinical practice. The first is definitive diagnosis. It can help staging and grading of cancer. It can guide surgical management. It can direct targeted therapy, which is also called the personalized medicine or personalized therapy. It can monitor response, treatment response, okay? And then we'll briefly look at the role of autopsy, okay? Just briefly, it's not extensive. Okay, definitive diagnosis. This is the very crucial role of the histopathology to clinicians. Of course, the confirmatory that gives a confirmatory diagnosis of what is happening. Time for break. Why is it? Okay. So, like I was saying, this is the first and most crucial making diagnosis, confirmatory diagnosis of the cancer. We all know that blood tests, of course, when you do them, they can signal the presence of a disease condition, but histopathology actually will tell you exactly what the problem is. That is, it will confirm the diagnosis for you rather than suggesting, just like blood tests would do. In so doing, it can differentiate. It can tell you the differentiation of the tumor, whether it is a benign tumor or it's a malignant tumor, okay? It can also tell you the histological types of that particular tumor, okay? If it's cancer, for instance, if you take breast cancer, it can tell you the subtypes, the histological types of breast cancer specifically, okay? It can also help in inflammatory disease condition, okay, infectious disease condition, and even autoimmune disorders, okay? Like if you pick inflammatory bowel disease, for instance, Crohn's disease, and ulcerative colitis, you can make this diagnosis histologically, okay? Infectious disease conditions like TB, Helicobacter pylori, schistosomiasis, parasites, and what have you, and some other autoimmune diseases. These are what diagnoses that can be made on tissues by histopathologists, okay? It can help you in staging of cancers, this staging and grading of cancer. Grading is histologically done. It measures the abnormality of the cell or how the abnormal the cell looks. And so it gives you an idea of how aggressive the cancer can be, whether it is well differentiated, it's moderately differentiated, or it's a poorly differentiated tumor. And we all know the significance of this because it guides your treatment, yes, because well differentiated tumor has good prognosis, and a poorly differentiated one, a poor prognosis, and so it helps guide the clinician on how to actually treat these cases. Staging, histopathology can help stage tumors for clinicians. It can assess the depth of tumor invasion and whether the tumor has spread to adjacent tissues or to even adjacent lymph nodes. Okay, because if you have a tumor, for instance, adenocarcinoma of the colon, and okay, let me use an example of breast. If you have a breast invasive carcinoma of the breast, and there are associated lymph nodes that have been harvested and sent. When you see that the lymph nodes are invaded by these tumor cells, of course, it tells you the staging, that the disease has gone beyond early disease. It's now late disease, and this will all guide the clinician or inform the clinician on the level of management. Okay. The third is it guides surgical management. Uh, Histopathology is deeply integrated into the operating room, okay, to help surgeons make real-time life-changing decisions. Okay, an example is the frozen sections. This frozen section is part of what is called the intra-operative consultation, where the pathologist can rapidly analyze tissue during an operation to tell the surgeon whether a tumor is completely removed or if more tissues must be excised. Okay, a surgeon is, a clinician is doing an operation and doesn't know in real time on the operating table. The tissues can be quickly analyzed by the pathologist, okay? And it can guide the surgeon or the clinician on the, the excision edges of the tumor, okay, whether it is adequate or not, okay? It can also be done when the tissue are removed surgically and are submitted, okay? If you have, let's say, a resected bowel, colon, for instance, and you have resected and have sent, the margins of these resected ends can also post-surgically can be examined, and this would also inform the surgeon if his surgery is adequate or not, okay? It can also guide targeted therapy. Modern histopathology relies heavily on techniques like the immunohistochemistry, which uses antibodies to detect specific proteins and genetic markers in tissues. This allows clinicians to use targeted therapies tailored to the unique molecular profile of an individual disease. Example is the hormone receptor testing in breast cancer. This is a modern tool that it's very key when you talk about personalized medicine or directed targeted therapy on individual, because it is said that for some tumors, let's take the breast for instance, sometimes okay. Okay. Histopathology can help in your monitoring of treatment response. Okay, you are treating a patient for a particular tumor, for instance, cancer, and you want to see if your therapy is working or not, your chemotherapy is working or not. If you can take the tissue specimen, histopathology can actually tell you if the treatment is effective or not, because when it is examined, it will actually show how the chemotherapy are killing the tumor cells or not. And so it will help the clinician take appropriate decision. Autopsy is also a diagnostic tool in histopathology, and it is very crucial for clinicians also. Autopsy is an examination of a body in order to determine the cause of death. Okay, and you have two types: the medical legal autopsy, which is also the coronal or the forensic type, and the hospital-based or clinical autopsy. The hospital-based or clinical autopsy is the type that is done in the hospital, and it doesn't really have a legal basis, or rather a medical legal indication, so to say. This one is usually done for its use, which include it can help you determine the cause of death. A clinician is treating a patient and the patient died. It can actually tell you what has actually killed this patient. Okay, it can also help you, the clinician, to determine and clarify clinical diagnosis. Okay, you are treating a patient for, let's say, liver cancer or liver cirrhosis and any other disease condition, and patients have died. Of course, probably you are thinking of a different, or rather you have your differentials in mind prior to the death of this patient. It can tell you exactly your clinical diagnosis, whether it is correct or not, and even your management. Okay, how you manage the patient, it can also help clarify. Okay, it can also be used as research purpose. Okay, it can be used for medical education. Okay, to teach medical students, to teach resident doctors. Okay, and it can also be used for organ transplants. For medical legal or forensic autopsies, these are the cases that usually on inquest or request by the coroner. Okay, the coroner is a designated authority that is authorized to order for an autopsy. Okay, with the sole purpose of determining the cause of death. And usually these are done for certain indications. If you have to, first of all, determine cause of death, it can also to identify an unknown corpse. It can be done for deaths in prisons or custodies. Okay. It can be done for accidents, cases. Someone has had accident and died, of course. It's an indication for forensic or coroner autopsy. Okay. In cases of poisoning, okay, someone has died of a suspected case of poisoning, of course. medical legal autopsy, it's an indication for medical legal autopsy. Okay? Cases of suicide, homicides, infanticides, they are all drowning, okay? Cases of drowning, it's also an indication for medical legal. There are so many of them like that. This is just to highlight, because a lot of people, a lot of clinicians are afraid of autopsies. And so these are some of the benefits that autopsies can actually give to clinicians, okay, or enhance clinician in their practice. Okay. In conclusion, for proper patient care and treatment, a confirmatory diagnosis is needed, for which histopathology is an indispensable tool, especially surgically removed tissues, for which they must not be thrown away. It can also help reduce certain cases of medical legal incidences in clinical practice. Thank you for listening. These are my references.
Thank you very much, Dr. Titus, for the very erudite and explanatory presentation. At this point, I'd like to invite any questions from any of the participants. You can choose to note your questions. Before the questions come up, let me start by asking a question. In our emergency unit here, we usually have a lot of cases whereby corpses are brought in, or we have police escorting some of these patients. And in some of those cases, they later come back to request for, is it autopsy reports? They bring a form that was supposed to fill for court proceedings. Is it in all cases that we have to call for the pathologist to do an autopsy, or there's a role for the regular casualty doctors to do one or two things before calling the pathologist? And if so, what are the cases and the exceptions? Thank you, sir.
Okay, thank you for the question. When corpses are brought, or a corpse is brought to the accident and emergency, what the casualty officer usually does is, or his function, is to examine the corpse and document findings on the corpse. You understand? All the injuries or the lesions on that corpse will be documented, and that is what is usually given to the police. You understand? But if it's to determine the cause of death, because just that examination that the casualty officer will do in A&E is not sufficient to determine cause of death in this patient. Okay, so if for the police to determine cause of death, you understand, it has to, an autopsy has to be done, and it's usually the pathologist that conduct an autopsy, because it's all encompassing. It's a thorough examination where both the physical examination, the internal organs are dissected and examined with histology. Alongside the tissue samples are taken for histology. And so it's a comprehensive examination that is done by the pathologist. And that is the only way that it can be determined that this is the cause of death of this of the body that was brought. Okay.
Thank you very much, sir. I can see some questions in the chat box. The first question is, must the government overrule a family in the quest to determine the cause of death of their relation? I'll take it again. Must the government overrule a family in the quest to determine the cause of death of their relation?
Okay. Well, it depends. If it depends on the state law, you understand. For instance, there was a time that the Lagos State actually had a law where all deaths are investigated. You understand? So it means autopsies would be carried out for every death that occurred. You understand? In that instance, I think the government policy or the government policy can override that of a family. But otherwise, if there's no state law that actually stipulates such, of course, the family decides whether they want to do an autopsy or not. Okay.
The next question is there any time frame for autopsy to be done in order to get the cause of death? Is there any time frame for autopsy to be done in order to get the cause of death? And the last question on this statement is, if a tissue looks healthy or non-malignant after removal, is there any need to subject it to histopathology? If the tissue looks healthy or non-malignant after removal, is there any need to subject it to histopathology? Thank you, sir.
Okay. There's no actual time frame. You understand? Yes, for autopsy to be conducted, provided the body can be preserved for such a time. Okay, but the earlier the autopsy is done, the better. You understand? The better you can get your findings. Okay, and if you take, for instance, an embalmed body, once you have embalmed the body, it is usually difficult to determine cause of death, and other findings will be blood, sort of. Okay. The last one, if a tissue looks healthy or non-malignant after removal, is there any need to subject it? As a matter of fact, this is the reason that informed this presentation. There are up till now, there are clinicians who in their practice, particularly in the interiors, they remove tissues and they throw them away. Or rather, they don't see the need to actually inform patients and their relatives that treatment is not yet over. You understand? This specimen has to be subjected to histopathology diagnosis. You understand? For the confirmatory diagnosis to be made before a patient can actually be released. You understand? Yes, you can never tell when you surgically remove a tissue what it is. And so, as a rule, any tissue at all that is taken out of the human body must be subjected to histopathology. Okay? It's a rule that it must be, because you may remove a lipoma, for instance, and you think it's just a lipoma because it's looking yellowish and from the color and all the rest, you think it's a lipoma. But it could turn out to be a malignancy of maybe a malignant lesion of a malignant tumor of fat. You understand? Like liposarcoma, for instance. You understand? It may shock you. And so it is, you can never say that, yes, you have removed this and so patient is okay. No, until you have subjected it to histopathology before you can actually say You understand that? Yes, this is either malignant or is benign. And so patient treatment option for the patient is okay. Or you go for that to treat.
Thank you very much, sir. We've now come to the end.
Thank you. Yeah, well done, sir.
So our next presenter is around, and he's by name. He'll be standing in for physiotherapist Umar Yahaya, and his name is physiotherapist Valentine Atiri, and he's director of physiotherapy in Taraba State. He'll be taking us on the role of physiotherapy in clinical care.
Thank you very much. Good evening, ladies and gentlemen. It's my pleasure to be here. I go by the name Valentine Atiri. I'm Director of Physiotherapy, Taraba State. I'm standing in for Umar. The topic I'll be taking is the role of physiotherapy in healthcare. So for us to define the role, we are going to have to define what physiotherapy means and what physiotherapy intervention can do for patients. Basically, physiotherapy is a branch of medical science that aims to restore proper functioning of disabled or injured body parts. It can also be referred to as physical therapy, and it involves assessment, evaluation, diagnosing, and treating of a range of diseases disorders, and disabilities using physical means. So physiotherapy can be the preservation, enhancement, or restoration of movement and physical function impaired or threatened by disability, injury, or diseases. And it utilizes therapeutic exercises, physical modalities like massage and electrotherapy. It also involves assistive devices and patient education and training. Physiotherapy is also a primary health care that aims at enhancing mobility, physical independence, and improving quality of life. Physiotherapy is focused on treating a variety of conditions, promoting health and well-being, and is usually prescribed for individuals who vary in age and athletic ability. What does the physiotherapist do? Basically, physiotherapists assess and diagnose condition. They evaluate patients' movement, joint mobility, and functional limitations so that they can treat using patients' education, exercise, electrotherapy, and manual therapy. They also rehabilitate to achieve the best functional recuperation after injury or disease. Who is a physiotherapist? A physiotherapist is trained in the study of anatomy and physiology, which is aimed at clinical reasoning. They are also lifelong learners committed to evidence-based decision-making for the good of the patient. Physiotherapists are licensed and regulated health professionals with a unique professional title. Only registered physiotherapists can provide physiotherapy services, and they are skilled in health promotion, injury prevention, and patient management. What exactly do physiotherapists do? They assess patients based on their age and medical conditions. And the conditions can range from sprained ankles to strokes. Physiotherapists relieve physical pain and help heal injuries, thereby increasing mobility, building strength, improve balance, and enhance cardiovascular performance. Who needs a physiotherapist? Physiotherapists engage clients by prescribing therapeutic exercises and teach clients to better manage their own health. There are some misconceptions about physiotherapy. Some of the misconceptions are physiotherapists are sometimes viewed or seen as services rendered only to athletes or people that feel pain. It is also needed after major surgeries, while in reality, physiotherapy helps people of all ages to manage chronic pain, to improve balance, and prevent everyday injuries without causing needless agony. Physiotherapy can be given to people or patients that are recovering from injuries. Physiotherapy can be used to manage chronic pain and improve mobility. Key groups of individuals that need physiotherapies can be sportsmen, older adults with balance issues, and patients recovering from surgery and neurological conditions. Physiotherapy is generally functioned in hospitals, rehabilitation centers, private clinics, and sometimes they make home visits, and they are also involved in the field of sports and community-based centers. Divisions of physiotherapy. Physiotherapy is broadly divided into pediatric physiotherapy, geriatric physiotherapy, sports physiotherapy, and orthopedic physiotherapy. Some of the branches of physiotherapy is highlighted below. Medicine and neurological physiotherapy, orthopedic physiotherapy, musculoskeletal physiotherapy, cardiorespiratory physiotherapy, community-based rehabilitation, and women's health. Physiotherapy is also helping ICUs units. Physiotherapists treat conditions that can be medical condition, neurological condition, developmental delay, Parkinson's disease, spinal cord injury, stroke. The benefits of physiotherapy include improved balance and coordination, improving of strength, improving of flexibility, and general function. Physiotherapy also increases the ability to manage daily tasks, including all activities of daily living. It can also reduce and modulate pain, and it can also be used psychologically to improve patients and people's mood. Generally, physiotherapy is needed in the orthopedic management of different conditions like low back pain, neck pain, arthritis, osteoarthritis, fractures or sprains, joint replacements, and in sport injuries generally. It helps to decrease pain, improve joint mobility and strength, and restore physical function and prevent injuries. Physiotherapy also functions in cardiorespiratory units to improve patients that have conditions like chronic obstructive pulmonary diseases, cystic fibrosis, heart diseases of various kinds, respiratory infections, and in post-surgical care. As mentioned earlier, it will improve patients' breathing and secretion clearance. It can reduce breathlessness and increase endurance, and it can also increase muscle strength both in the arms and in the limbs. Physiotherapy is also functioned in women's health in the area of relieving chronic pelvic pain, incontinence, thereby reducing post-surgical pain and swelling, and it can improve or reduce pelvic pain, and also generally it can improve urinary incontinence. Physiotherapists make use of electrotherapy. In electrotherapy, these are various electrical devices like TENS, which is an acronym for transcutaneous electrical nerve stimulation, We use it in cases where limbs are paralyzed, for example, stroke. We can use it to slowly rehabilitate a paralyzed limb. Physiotherapists also use exercise therapy to improve strength and balance. Hydrotherapy or treatment in water is also a form of physical modalities that physiotherapists use. Some of the machines or modalities that physiotherapists make use of are infrared radiation, shortwave diathermy machine, medium wave diathermy machine, electrical stimulation, and wax therapy. In terms of exercises, we give passive exercises, active exercises, strengthening exercises, stretching exercises, breathing exercises. All these are forms of exercise therapy that help to improve patients' condition. The primary challenge in the practice of physiotherapy in our local settings are listed below. Sometimes the institutional, there's this kind of bias that kind of restricts physiotherapy practice. Then there's limited resources. Then also interpersonal relationship with other healthcare professions. There's delayed referrals where patients are supposed to be referred at a certain time, but there's a delay of one form or the other. Then sometimes the roles of physiotherapists is misunderstood by some of the other health professionals. Then physiotherapists are generally limited to big cities and state capitals. So there's limited access to the inland or villages where some of the people need physiotherapeutic intervention for some of the conditions they suffer from. The following will go a long way in improving physiotherapy practice: interprofessional collaboration, early referral, community-based collaboration, and discouragement of some harmful traditional practices. Then discouragement of quackery and unethical practices. Thank you.
Thank you very much, physiotherapist Valentine, for the presentation. At this point, we would like to invite any questions or comments on the topic at hand. You can either note it in the chat box or indicate by raising of the digital hand so I can recognize you to speak. The first question here is, please, is there any place for physiotherapy for chronic waist pain? I'll take it again. Please, is there any place for physiotherapy for chronic waist pain? Over to you, sir.
Thank you very much for the question. In the case of a patient or a condition of a chronic waist pain, physiotherapy actually plays a very, very important role. Once the pain becomes chronic, then physiotherapy comes in the sense that people that generally have chronic waist pain, most of the time, they have been prescribed various analgesics with little or no improvement. So when physiotherapists come in, most of the patients, 90% of them, they get relief by physiotherapy, because we have various modalities that we can use to relieve. If it is nerve compression, improve the patient's stability and strength with exercise therapy. In fact, when pain becomes chronic, physiotherapy should be contacted, because we have up to 80% success rate in improving such conditions. So we have a deep role to play in any pain that is chronic. Thank you.
Thank you very much. Another question here says, please, what constitutes a delay of referral in physiotherapy? Can you give an example for better understanding? I'll take the question again. Please, what constitutes a delay referral in physiotherapy? Can you give an example for better understanding? Thank you, sir.
Thank you very much for the question. I'll give an example. There was a certain physician at specialist hospital that were managing a burn patient. So this physician came to us and actually said that he doesn't know when to refer the burn patient for physiotherapy. So for a case like that, once a burn patient is stabilized, burn patient should be referred immediately for physiotherapy, because we carry out saline baths, and as the wound is healing, we are doing stretching exercises, because all of us know that in terms of burns management, contractions can be the real deformity. So as the wound is healing, as new skin is coming, we are carrying out stretching exercise to stretch the joints and make sure that there are no contractions. So for burn patients, if they don't refer the patient for physiotherapy in time, sometimes they come too late, so it can constitute delayed referral. Then some patients who that have chronic back pain, maybe chronic lumbosacral spondylosis. I've met several patients. In fact, there was a case of a tanker driver that had spondylosis, and each month the patient reports to the GOPD for new group of painkillers to be prescribed for him. And he has been doing that, according to him, for more than 8 months. So that can constitute delayed referral. I think after the first month or latest second month, such a patient should be referred for physiotherapy. And there's evidence-based treatment that will give the patient that will, most of the time, at least 80% of patients will be relieved. So that too can constitute delayed referral. Thank you.
Wow, thank you so much for the responses. So add a few questions. First of all, of the services which were mentioned in the presentation, which of them are available and where are they available? Of the services mentioned that are available, which of them are available in Taraba State and where can they be accessed? And secondly, the current FAD is 8,000 steps a day in order to maintain health. Can you speak to this? The current FAD of 8,000 steps a day to maintain good health. Please, can you speak to it? Thank you very much.
Okay. The first question, I'll take that. Physiotherapy service is generally available in Jalingo here in Taraba State, either at the Federal Medical Center here or at the specialist hospital. So there, we practice general physiotherapy. So patients that need orthopedic physiotherapy, pediatric physiotherapy, geriatric physiotherapy, and the women's health can get all these services that involves physiotherapeutic intervention. We are there at the Federal Medical Center or the specialist hospital for referral. The second question, 8,000 steps per day, talks about maintaining health. Generally, the psychology of Nigerians is we don't have exercise psychology in Nigeria. We have a situation where we don't feel that exercise is important for ultimate health, especially for adults. Sometimes, when you are going on maybe walking or light jogging, you see people, they park and they come and ask you that, what is wrong with the car? Why are you not using the car? So 8,000 steps per day is the basic exercise that is required for a human being to maintain ultimate health. Research has shown that if you do that, you are likely going to live longer than your peers that just walk from the bedroom to their cars, from their cars to the office, then from the office back, not doing any exercise. And everybody knows that exercises generally improve health, can even stop you from developing conditions like hypertension and diabetes. So 8,000 steps per day is the basic movement that every human being needs to maintain ultimate health. But we as physiotherapists, we are even prescribing that apart from 8,000 steps per day, every adult that is over 25 should be able to either walk briefly or carry out light jogging that will make you breathe a bit faster for 15 to 30 minutes, 3 times a week. Thank you.
Thank you very much for the response. The last question here is speech therapy part of the scope of physiotherapy, or is it a different specialty on its own? I'll take it again. Is speech therapy part of the scope of physiotherapy, or is it a different specialty on its own? Thank you.
Thank you very much for the question. Generally, speech therapy is not part of the scope of physiotherapy. The only thing that links us with speech therapists is that in Nigeria, we are registered under the same board, the speech therapists. But there's a constraint here. Because speech therapists are very, very scarce in Nigeria. They are very scarce. So in the training of physiotherapists in Nigeria, speech therapists has been introduced just for us to help, especially people in the villages. So we find out that we are in a situation where in Nigeria, we are not speech therapists, but we carry out speech therapy because we are the closest to the speech therapists. And we cannot just watch patients deteriorate. So we try as our best to kind of give them a little bit of speech therapy that we have been trained in. But for patients that can afford it, we refer them to Lagos or Abuja, where they can get the services of qualified speech therapists. But for those that cannot afford it, we just stand in for speech therapy, where we teach them the basic things that can improve their speech. In case of patients that have maybe stroke, the thing that affected the speech. Thank you.
Thank you very, very much for the presentation. In the absence of any further questions, the next question. Physiotherapy, even in the management of our patients, and the general upkeep of health. Thank you, sir, for your presentation. At this point, we then invite our next speaker, who is Dr. Kuni. We'll be introducing you shortly, so please stay on. Thank you.
Thank you. Well done, sir. How is everything?
can start.
Thank you very much for staying with us. For our next presentation, we have the head of the department of the Department of Otorhinolaryngology, also known as ENT surgery, with us. He's also the former CMAC of Federal Medical Center here in Jalingo. And it's our pleasure to introduce Dr. Kuni, who will be taking us on the topic ENT emergencies for general practitioners. Thank you very much, sir. And you have the floor, sir.
Okay, good. The NMA chairman and his team, our CMA coordinator and his team, my senior colleagues, our ICT team, good day to you all. It is my pleasure to be invited to talk on this topic briefly in the next few minutes. The topic is ENT emergencies for general practitioners. This time, general practitioners here is an encapsulated word because not just those in general practice that needs this knowledge. Even specialists in other fields, they need this knowledge because there's nothing that prevents you in your specialized clinic seeing ENT emergencies. You may be in a hospital where these patients may actually present to you, or your patients will present with some of these conditions to you. So at that level, you have to use the knowledge you acquire as a general practitioner to sort them out so that the prognosis at the end of it all will be better than if we don't have anything to offer at all. Thank you very much. So I'm going to discuss this topic under the following heading: Introduction, Basic Anatomy, Classification of ENT Emergencies, Principle of Management of ENT Emergencies, and we'll talk briefly on the diagnosis and treatment of some common ENT emergencies. Then we'll conclude. By way of introduction, ear, nose, and throat emergencies are common presentations in general practice and our emergency departments. They range from minor disorder to life-threatening conditions that demand rapid recognition and prompt management. ENT emergencies, that's ear, nose, and throat emergencies, can compromise airway, breathing, and hearing. As such, early intervention by the general practitioner or the first contact physician can be life-saving and prevent complications. Understanding the basic assessments and stabilization principles ensures safe patient care before referral. This is the basic anatomy. If you look at it, these pictures, the first one shows what we mean by the nose or rhinological structures. It includes the nasal cavity, the nasal pyramid, and the sinuses. We have the maxillary sinus, the ethmoid, and the frontal that we can see facing us by the side of the nose. But when we look at it from the lateral view, the sphenoid sinus is also part of the rhinological structures, and it is just behind the, and you can see it just behind. And the ear, we have the pinna, the external ear, and the middle ear and the inner ear. All these are the otological structure or ear structures, where the throat involves the oropharynx, the nasopharynx, the larynx, the trachea, the esophagus, while the neck involves all the visceral structures and other components of the anterior neck. So this emergency that we are referring to are emergencies that can come up from these basic structures that I have mentioned.
And the aim of this presentation is that at the end of this, general practitioners should be able to identify common ENT emergencies seen in the general practice, recognize red flag symptoms and signs, that's danger, the dangerous symptoms and signs, and outline principle of immediate management that is required before these patients are referred to the ENT specialist. And they should also be able to determine when to refer urgently to the otorhinolaryngological specialist for definitive intervention. Classification of these otorhinolaryngological emergencies, as I've mentioned earlier, those that are from the of otological origin, that is the ear, those that are of rhinological origin, that is the nose, and those that are from the throat and neck. This is how we can group them. So for the ear emergencies, we think of penile laceration and hematoma, foreign bodies in the ear, acute otitis media, with complications, traumatic perforation of the TM, sudden hearing loss, and sudden vertigo. From the nose, you have nasal foreign body, nasal bleeding or epistaxis, septal hematoma, abscesses, acute sinusitis with orbital complications, nasal fractures, and bilateral guanal atresia. These are the common emergencies that can affect most of the structures I've mentioned earlier. From the throat and neck, we have acute tonsillitis, foreign bodies in the throat, acute epiglottitis and laryngitis, laryngotrachea trauma, fume inhalation, cord throat injury, deep neck space infection, tonsillar hemorrhage, and acute laryngotracheal bronchitis. So these are the common emergencies that we come in contact with as first physicians to see these patients. And when you come in contact with these patients, there are red flags that whenever you pick them, there is need to do something and refer urgently for definitive treatment. These red flags include stridor, that's noisy breathing and respiratory distress, drooling of saliva or inability to swallow or painful swallowing or discomfort in swallowing, rapidly progressing swelling, a swelling in the throat, in the nose, in the ear, or in the neck that is increasing rapidly, persisting epistaxis, that's bleeding from the nose that is persisting, and also bleeding from the ears, throat, and neck, severe ear pain with some cranial nerve pulses, sudden hearing loss. These are symptoms and signs that needs urgent attention. So when you see them in such patients, there is need to refer immediately to stabilize and refer immediately for definitive treatment. So the principle of management of this patient as a general practitioner in your facility or where you work, there is need to have some basic things to save the lives of this category of patients. There is need for prompt diagnosis. The principle of the care is prompt diagnosis. It mostly is clinical, but sometimes radiological and blood tests can be of help. You need to resuscitate this patient, to know how to resuscitate them or stabilize this patient, ensure that the airway is patent, this patient are breathing well, the oxygen saturation is good, and that if they need fluid, they should have it. Then the environment where you work, you need to have adequate illumination and the right instrument to assist this patient. Illumination in the sense that the nose, the ear, and the throat, they are actually small cavities, and you can't walk or do anything there without a very good light source. And these instruments are things that will help you save the life of this patient. That is by sucking out blood or secretion by making sure that the airway is secure, by ensuring that the foreign body are removed, by ensuring that the bleeding spots are cauterized, and also to know their status. All these things are very important. You need to have them in your facility so that you'll be able to render something to this patient. The cooperation of this patient, very important, because the side of the pathology are not easily accessible. So you need the cooperation of this patient. In some instances, you will have to sedate or anesthetize this patient to be able to help them out and stabilize them before you refer. You may need systemic antibiotics, adequate analgesia, oxygen therapy with the right nasal prong, face mask, and the trachea tube, steroid, and you also need to have items that will enable you carry out an aseptic techniques so that in the course of trying to save these patients, you don't introduce infection into their throat, ear, or nose, or they don't infect you on the process. So you need to protect yourself as you try to save their lives. So the diagnosis and treatment of common ENT emergency, basically they are emergencies. Resuscitation goes along with clinical history, clinical examination, investigation if need be, and the treatment. As we all know, the basic principle of the care of emergencies. And the ear emergencies, as I've mentioned earlier, they are emergencies that can occur from either in the outer ear, the middle ear, or the inner ear. The outer ear starts from the pinna. The pinna, the external auditory canal, as shown in this diagram, up to the level of the tympanic membrane, while the middle ear starts from the tympanic membrane down to the oval and round window and via the excision tube, including the excision tube. Then the inner ear starts from the oval window to the level where the vestibular and cochlear nerve exit into the brain. These structures, emergency, can come up from any of them. And to look at them gradually, this is what we say penile hematoma. It's one of the emergency that this patient with this condition can present in our accident and emergency or in our centers as general practitioners. They will present with the swelling as shown in this patient. It may look bluish, it may look reddish, and it needs attention because of what we will discuss. As I said, the first pathology is penile laceration or hematoma, commonly seen in wrestlers or people that are involved in road traffic accident or assault. When the penile is lacerated or avulsed or swollen or is associated with pain and bleeding, the diagnosis is mainly clinical. And if it is hematoma, the main fear there is that of cartilage necrosis. This is because the penile cartilage has no direct blood supply. It depends on the blood supply from the perichondrium. And when there is hematoma, the blood usually collects between the penile cartilage and the perichondrium that covers it. That actually prevents the perichondrium, prevent the cartilage from getting its blood supply from the perichondrium, and that leads to penile necrosis. It is an emergency because if you allow it to continue, the cartilage will get necrotic and dissolve, and the patient will end up having a deformed penile that will not be able to carry out its function appropriately. What we need to do when these patients present is go to drain the hematoma, either by a needle aspiration or I&D. Then we evacuate the clot. We cover the patient with antibiotics and analgesic. We apply bulky ear dressing to prevent recurrence collection of the hematoma. Then we follow up these patients closely because there is a very high tendency that this hematoma may recollect. In a situation where all this bulky pressure dressing is not working, sometimes we use button. We apply one behind and one over the side of the hematoma and put suture to secure them. That one will give us good pressure. Then we observe the patient and allow the patient to be on the pain reliever and antibiotic for some time before we remove the buttons if the bulky ear dressing is not working. In case of laceration, the thing there is that if it is avulsed, sometimes the outcome is not usually too good. But the whole thing remains that there has to be a tag. If there is a tag that will form a graft that will give blood supply to the avulsed side, you can actually refreshen the edges and suture it back as soon as possible. When you do that, the outcome is actually good. And in suturing laceration, single layer closure, very, very good. And you need to ensure that the perichondrium, which is the main source of blood supply to the penile cartilage, are posed appropriately when you are doing the suturing. Bulk ear dressing, that's pressure dressing on either side to make sure that you stabilize the penile after suturing is very important. And you need to follow this patient up with antibiotics and analgesic and close follow-up because of the trauma and the work that we've done there, there is a very high tendency of hematoma formation. So you need to follow these patients closely. Then acute otitis externa is one of the common conditions that patients present with in our general outpatient practice, especially at the emergency unit. When you look at this external ear, you see that the pinna is hyperemic, the external auditory canal is swollen and with a discharge around it. That is to show that this patient has acute otitis external. They usually present with pain, hearing loss, and so on. So, as I've mentioned earlier, acute otitis externa is infection and inflammation of the outer ear, start from the pinna to the external auditory canal, and they usually present with pains, watery or purulent ear discharge, hearing loss, and sometimes tinnitus. The common causes are usually bacteria, fungi, and viruses. The treatment is mainly cleaning and toileting or suctioning the ear canal if it is still open. And as we've seen earlier in the picture, you need to clean that ear, you need to suck the external auditory canal, you need or toilet the external auditory canal. Then you can follow them up with antibiotics or antifungal depending on the cause. Ear drop with or without steroid to help in minimizing edema. Then analgesic and antibiotics, oral or parenteral, can be given depending on the state at which the patient presents to you as a general practitioner or in your clinic. Use of wig for tight canal, like the picture that we've earlier shown, the canal there is so tight. If you say you use ear drop directly, it will not enter. It will actually come out. So there is, after toileting and cleaning, there is need to use a gauze wig, soak it in the ear drop or antifungal, in the antibiotic ear drop or antifungal ear drop, and actually try to push it into the external auditory canal while you continue to drop the ear drop on it. That way will help in carrying the ear drop into the external auditory canal. By so doing, the medication will get to where you want it to reach and the condition will resolve faster. in patients with diabetic and immunocompromised patients who present with these conditions, you need to actually be careful in handling them because some of them their condition may result into what we call malignant otitis externa, and that needs immediate referral. This malignant otitis externa is an aggressive one because depending on the organism that causes it, it extends to, apart from the ordinary inflammation that you see in ordinary otitis media, otitis externa, it can result to necrosis of all the soft tissues and even bone at the base of the skull. So if patient present with acute otitis externa and is known to be diabetic or immunocompromised, if the basic treatment is not taking care of the problem, it is better to refer so that definitive intervention can be offered to this patient. Acute otitis media with complications. Acute otitis media, they are actually common emergency that present to general practitioners and our emergency unit. Complications of acute otitis media can be tympanic membrane perforation, mastocytitis, facial non-passive, or extratemporal or intracranial extension. Looking at the position of the middle ear, it can extend either way. And these patients usually present with otalgia, that's pain in the ear, otorrhea, discharge from the ear, hearing loss, noise in the ear, and fever. They usually precede upper respiratory tract infection. On physical examination, you will find out that the tympanic membrane may be dull or hyperemic. It may be intact, retracted, or bulging, or perforated with wide external auditory canal, depending on the stage of the disease at presentation. The treatment, if it is already perforated and the external auditory canal is wet with pus, the best thing is to first toilet the external auditory canal, ensure that the external auditory canal is kept dry. That's we instruct the patient to use Vaseline on his or her palm, cut a little piece of cotton wool, roll it to form a ball. That Vaseline will form like a leather around the ball of cotton wool. He will be blocking the ear with it. When he wants to bath, after bathing, he can throw it. If he is entering rain, he can use umbrella to prevent water from entering that ear. He can actually use systemic antibiotics, analgesic, and decongestant to dry up the secretion in the middle ear and allow healing of the perforated tympanic membrane to take place. Avoid ear drops at this stage. This is very important because in the acute phase, the tympanic membrane and the middle ear is inflamed. The vessels are actually exposed. So if most of the ear drops that we use are ototoxic. So when you apply them, this ototoxic ear drop can be absorbed and into the vessels and damage the structures in the inner ear. And you see these patients coming down with hearing loss that is not actually agreeing with the acute otitis media that the patient presents with. So we need to be very careful. We don't use ear drop in acute otitis media. And it is also good to emphasize that early referral to otorhinolaryngologist is life-saving if symptoms persist after the basic treatment as outlined. Sudden hearing loss is also one of the emergency situations, emergency otological situations that patients present. It is also termed sudden sensorineural hearing loss. It is a medical emergency with so many controversies. The main definition of it is the rapid loss of hearing of at least 30 decibels in 3 contiguous frequencies over a period of 3 days. The etiology is actually idiopathic, though viral, vascular, and autoimmune has been implicated. Evaluation, that is history and examination, are actually done to exclude other causes. As I've mentioned, the etiology is actually idiopathic, to exclude other causes of hearing loss of that sudden nature. Geometric assessment is very important also in this case too, so that we'll be able to know the type, pattern, and severity of hearing loss in this patient. MRI and CT scan is also done to exclude other causes before we can now tag it as sudden sensorineural hearing loss, because the cause is actually not done. And the treatment depends on the clinician's assessment. But the mainstay of treatment is actually prednisolone, 1 milligram per kg per day for like 2 weeks for the start, or 10 to 14 days for the start, to observe whether there is a response or not. Prednisolone or Dexa can actually be used in a situation where you suspect there is a viral attribute, because we cannot, in primary healthcare centers where general practitioners work, or if we make this patient, especially somewhere where we cannot diagnose viral situation, you can start antiviral, because this has been implicated as one of the causes too. Antibiotics also can be used depending on the clinician's assessment, and also dietary and lifestyle modification and restriction. That is restriction of caffeine and cessation of smoking is also important in patients that you're suspecting sudden sensorineural hearing loss. It remains one of the most interesting and disputed topic, because it presents with symptoms of an emergency without convincing cause or reliable treatment. That is okay. So when we want to look at the rhinological emergency, this is just a picture to show the lateral wall of the nose, because what I presented earlier is just the nasal pyramid. The lateral wall of the nose, you have the turbinates and the mitosis. The septum, which is the medial wall of the nasal cavity, we have the septal cartilage, the perpendicular plate of the ethmoid, and the vomer bone. All these are covered by nasal membrane, and this one shows just the vascular anatomy of the nasal cavity. In epistaxis, the common size of anterior bleeding is where we call the Kessenberg plexus, where we have so many vessels meet there. And these 4 main vessels actually meet there: the anterior ethmoid, the superior labial artery, the greater palatine, and the superior palatine. While the wardrobe area, the common site of posterior epistaxis, is also demonstrated, because we'll be mentioning them as we discuss epistaxis. This is when patients present, the bleeding can be from one nasal cavity, from both nasal cavity, or from both nasal cavity, and from the throat too. And sometimes it may the bleeding will just be coming from the mouth. That is to say that it is purely a posterior bleed. But in massive bleeding from both anterior or posterior, you'll find patients bleeding from both from both nasal cavities and from the mouth too. By way of definition, epistaxis, which is common presentation, is bleeding from the nose, most commonly from the anterior nasal septum, the Kessenberg plexus, as mentioned earlier. Most episodes are minor. As such, no intervention is usually required, and this usually occurs in children and adolescents. The causes can be local from the nasal cavities, as mentioned, or systemic conditions that can also present with epistasis. And the understanding of nasal vascular anatomy is very important in the care of this patient. The evaluation of this patient, first, you have to confirm the hemodynamic stability of this patient and airway patency. You have to know the pulse, you have to know the blood pressure, and you have to know the amount of blood loss before you are attending to the patient. Very important. And treatment of this patient depends on the cause, severity, location, and available items and the experience of the physician. All these are things that you need to have at the back of your mind to be able to take care of this patient properly. Some causes, as I mentioned earlier, the local causes, common non-speaking, most common cause, nasal septal deviation, neoplasm, infection, and nasal fracture are common local causes, while the systemic causes include decoagulopathy, hemophilia, renal and liver diseases, alcoholism, aspirin, insect. All these affect platelet function. Thrombocytopenia, decreased platelet, viral hemorrhagic fever, vascular abnormalities, hypertension, and anticoagulants. All these, some of them affect, most of these anticoagulants, they are common things that we use for one reason or the other, but they affect platelet aggregation, and that predisposes patients to bleeding. And in the evaluation of this patient, as I've mentioned, bleeding can be is either from one nostril or both nostrils, blood in the throat, mainly because of posterior bleeding. You also want to know the quantity of blood loss, rough estimate of the blood loss. Then you now, the history of dizziness or generalized body weakness, very important, especially when patients have significant blood loss. Some of them may even present unconscious when they've lost so much blood. And
You now read
pallor,
verb,
dehydration,
how you form a singular verb. Okay, the singular verb.
So all this, I think the mic. Okay, all these are serious presentations that will need these patients to be referred immediately for definitive care. The management at the general practitioners setting assessment, the ABC of resuscitation has to be taken care of. We have to ensure that the airway of this patient is patent and that the patient is breathing well and the saturation is above 90 and that the circulation is okay, or we have to stabilize it. And we need to check vital signs, estimate blood loss, identify source if possible. If there is history of fever, trauma, drugs, or hypertension, we need to know as a general practitioner so that we'll be able to approach the care of this patient appropriately. Normally, for patients, generally, the first aid that is usually given is that if this patient is conscious, you need to sit the patient upright, leaning forward, give them a kidney dish so that anything that is coming from the mouth, that is collecting in the mouth or from the nose, they should be spitting in there and allow it to drop in the kidney dish we need to suck out all the clots in the nasal cavity, and we will now instruct, we do it, or we instruct them to pinch the soft part of the nose for 10 to 15 minutes and encourage mouth breathing. We can also apply cold compress. It is good here to note that the muscles of the nasal cavity function as that of the uterus. If there are clots there, the muscles will not contract well to prevent the bleeding. So we need to clear the nasal cavity of all clots. That is why, as a general practitioner, it is more comfortable to work where you have at least a sort of functional suction machine, so that when these situations present, you will be able to do something and stabilize the patient before you refer them for definitive care. If all these phase 8 plans failed, then we now, and the bleeding is persisting, that is when we now will need to use topical vasoconstrictors like xylometazoline or oxymetazoline or adrenaline, a soaked gauze or drop. We apply it to the bleeding site if we can locate the bleeding site. If it failed, we can now use chemical or electric cautery if the point of bleeding is identified. That, like the chemical cautery, just getting silver nitrate powder, having it in your lung, you just apply it there to solve the problem. The electric cautery, we have a silver nitrate pen. You just know the bleeding site, apply the tip of the pen there. It will coagulate the bleeders and the bleeding will stop. If all fail or you cannot see the bleeding site, despite all the sucking and all this, what we do is anterior nasal packing. That one, we impregnate the nasal packing with antibiotic, the gauze with antibiotics cream and lubricant like liquid paraffin for ease of removal. When you pack, any patient that has nasal packing must be covered with antibiotics for the fear of ascending infection. Then you admit the patient and observe. If this fail and the bleeding is severe, or in cases of posterior bleed, oxygen you may commence oxygen therapy if need be. You have to secure an IV access for fluid or blood and catheterization to monitor input and output. All these are done with other resuscitation process. Nasal packing may be done if all effort fail. If you are trained, you need to do nasal packing. But in our environment, the easiest way to do it is to pass a urethral catheter through the nasal cavity and inflate it with like 15 to 20 mils of air. Then you manipulate it into the nasopharynx and apply anterior packing and plaster it. By so doing, you will have exerted some pressure in the posterior guana where the posterior bleeding is coming from, and sometimes it helps to arrest the bleeding in this situation. In all, you need to cover any patient that has nasal packing with antibiotic for the fear of ascending infection. Nasal septal hematoma is one of the conditions that this patient usually present with. You can see this patient, see the nasal cavity, you see bulging from the septal aspect of the nose, from the medial wall of the nose. And this is actually an emergency. This is, as I've mentioned, it is collection of blood or hematoma. That's hematoma, or pus, that's abscess between the nasal septal cartilage and its mucosa covering. The cause is usually trauma, is the most common cause. Road traffic accidents, sport injuries, and fall. Post instrumentation and surgery are some of the common causes. Usually, if the septal hematoma is not treated properly, it leads to sepsis. Why it matters is that septal cartilage has no direct blood supply as in the penile cartilage that I've mentioned. And because of this collection, pressure from the hematoma leads to cartilage necrosis, and this can lead to saddle nose deformity. This is a true ENT emergency because if the nose is deformed or saddle, we know what the nose means to every individual. Your facial appearance, your beauty, and all this is in what the face presents. And if the nose is deformed, it will affect your appearance generally. And we know the psychological impact of that. And it also changes your voice. We know that the nose is one of the resonating chamber in speech. So it is actually very important. And the symptom of these conditions are actually nasal obstruction, which is usually bilateral, nasal pain, history of trauma, fever, and fever if there is abscess. And the signs are that when you prop this mass, it will be soft and fluctuant swelling on the nasal septum. That is, the lateral aspect of the mass will be free, while the media continues with the septum. It may be red or bluish bush inside the nose, and the septum may be tender and it may block both nasal cavity. It is good actually to differentiate this from hypertrophied inferior turbinates and nasal polyp. As a general practitioner, as I've mentioned, this septal hematoma, the free age is on the lateral part, that's away from the septum, where the mass continue with the mucosa of the nasal septum. Where in the turbinate, the free edge is medial and the mass continue with the lateral wall of the nasal cavity. While in polyp, the mass also continue with the lateral wall. But most of the time,
Give me that microphone.
as
Let me take from here.
it is not as it is not looking as tissue. The color gives the polyps out because it is jelly-like or grayish-like, not reddish as in inferior dominance. These are things that we need to know so that we'll be able to differentiate and diagnose them appropriately. So the red flags here are that bilateral nasal obstruction after trauma with fever and nasal swelling. And if the pain is increasing or the patient is not present in, it is good to refer because this septum is in the danger area of the face, the side that we call danger area of the face. Any infection there can actually spread into the brain and into the cavado-sinus thrombosis with deadly consequence. So we need to actually refer for definitive care. So in a general practitioner's setting assessment, we inspect the nose with light source, look for septal swelling on both sides, and differentiate it from inferior turbinate and polyps, as I've mentioned earlier, and gently palpate for fluctuant, then ask about history of trauma, which will likely be there. Then if you've confirmed that the septal hematoma, there is need for urgent referral for drainage. You can start antibiotics to prevent infection from setting in. And if it is abscess, it's actually a serious emergency, and urgent drainage plus IV antibiotics is necessary, and do not delay. As I've said, the septum is in the area of the face that we consider as a danger area of the face. An infection there, especially abscess there, can spread because of the valvulus connection between those danger area to the cavernous and the brain as a whole. Complications of a septal hematoma or abscess and septal cartilage necrosis, saddle nose deformities, as I've explained earlier. Septal perforation can occur if you don't drain it well. The key here is that if you want to drain septal hematoma or septal abscess, despite the fact that the swelling is on the two sides, you don't open the two sides. You open one side, pass through the the the, the cartilage to empty the other side, so that you can now put endotrachea to collapse this other side. If you drain the two sides, it's likely this patient may develop some complication that may lead to perforation, because the septal cartilage is already weakened by the pressure from either side. So, and intracranial spray is one of the complications. Indication for referral, as I've said, all suspected septal hematoma or abscesses, any nasal swelling after trauma, fever with nasal obstruction, all this needs to be referred. We talk of acute sinusitis with orbital complication. You see somebody with features of sinusitis and is coming down with orbital swelling, redness, pain on movement of the eye, and blurring of vision. This is actually a serious condition that needs attention. And as by way of definition, I would say it is spread of sinus infection, commonly from the ethmoid and maxillary into the orbit, leading to sight and life-threatening complications. The causes are normally untreated or severe acute sinusitis, acute respiratory tract infection, dental infection, more commonly because the ethmoid in children is because of the thin ethmoid bone in children. And complications are in spectrums from preseptal cellulitis, which is mild, to orbital cellulitis, subperiosteal abscess, and cavernous sinus thrombosis, because as I kept on mentioning, because of the danger area of the face. And sinusitis features, as I've said, facial pain, pressure, nasal discharge, which may be purulent, and fever and nasal congestion. And in this condition, when there's orbital involvement, you'll see that patient experience painful or restricted eye movement, eye swelling, that's periorbital edema, proptosis, that's bulging of the eye, reduced vision or diplopia, and gemosis conjunctival swelling. The red flags here is that when there is a reduced visual acuity, pain on eye movement in somebody that has sinusitis, or thermoplegia, proptosis, altered consciousness, and severe headache, which signifies intracranial spread of this infection. You need to refer this patient immediately for definitive intervention. In a general practice setting assessment, still A, B, C of life, that's airway, breathing, and circulation first, because we have to ensure that this patient is alive before you start anything. Then you check for visual acuity, that's for each eye, whether the sight is there or not, even by finger movement, by flashing of light, and the real, because you may not have the real visual acuity chart in your centers, but it is good to have them, because when you come in contact with this situation, you need the items to work with. Examine eye movement, inspect for swelling and proptosis, check vital signs, and you ask for the duration of the symptoms and the worsening symptoms, so that you'll be able to intervene appropriately. The immediate care that this patient will need is that if there is orbital complication, start broad spectrum IV antibiotics if available. Give an analgesic and monitor these patients closely. Then you refer to the ENT or ophthalmology for hospital admission and definitive management. The funny thing is that in some of our centers, these patients don't even have money to go anywhere. So you have to just admit and start this treatment aggressively before the source money to move. In my cases, you can give oral antibiotics and monitor these patients closely. And the complication, as I've mentioned, if you don't do anything much, this patient may lose their sight, which may be permanent. There may be orbital abscess, intracranial spread like meningitis, brain abscess, and cavernous sinus thrombosis may come up from simple sinusitis with orbital complication. You need to refer when there is any orbital sign in patient that has sinusitis that is not responding to the initial treatment, and children with severe symptoms, or if there is diagnostic uncertainty, you need to refer. Bilateral choana atresia. Congenital is a congenital blockage of the posterior nasal opening, which is the choana, on both sides, preventing nasal inflow. Why it matters is because newborn are obligate nasal breathers. So bilateral obstruction can cause severe respiratory distress, and that is actually a neonatal emergency. The cause, it is actually associated with the Charles syndrome, where this patient presents with coloboma, also have associated features of coloboma, heart defect, atresia choana, growth retardation, genital anomalies, and air anomalies. So in examining these patients that you suspect choana atresia, you need to examine all these structures to see the associated features. The key features of choana atresia is the classic triad of cyclical cyanosis, respiratory distress, and reliefs with crying. Other findings are difficulty in feeding, noisy breathing, and failure to pass nasal catheter. Cyclical in the sense that when the child cries, the sinuses tends to clear because the child is able to take in and take out air. But when the child is relaxed, they are obligate nasal breathers. The mouth is closed, so the child will not be able to breathe, and the sinuses will bounce back again. So the red flags here is that sinuses at rest is an indication that the child needs specialist intervention. Apnea episode and severe respiratory distress and inability to feed, because when they are feeding, the mouth is closed, so there will be no place for the child to breathe, and the child will not be able to feed. You have to remove the mouth from the breast so that you'll be able to get some air in and out. In the general practitioner setting assessment, we ensure that the airway is patent, breathing is good, and the saturation is okay, and the circulation is good. Observe breathing pattern of the child when you are in contact with these children, and attempt gentle passage of soft nasal catheter. Check oxygen saturation and look for associated abnormalities as mentioned earlier. The immediate management, which is life-saving, is to have an oropharyngeal airway. If you have an oropharyngeal airway in your facility, just putting that in the mouth will bypass the nasal obstruction, and you position this infant properly and give oxygen while you prepare to refer this patient for definitive care. Other supportive care are keeping the airway patent, monitor oxygen saturation, and prepare for definitive surgical management. Complication of this, if not taken care of, hypoxia with its sequelae can follow, feeding difficulties, failure to thrive, and death if untreated. Indication for referral as mentioned, if you suspect it is an emergency, you need to refer. Any neonate with cyclical cyanosis and failure to pass nasal catheter is choana atresia and need to be referred immediately. For the emergencies of the neck and throat, this one will present with pain, severe pain in the throat. You can call it fire in the throat. And the common emergency that can present like that are acute tonsillitis. It's actually acute inflammation of the tonsils. The cause is usually viral or bacteria. And symptoms are sore throat, painful swallowing, fever, malaise, and headache. Signs, when you examine the throat, include enlarged or red tonsils with tonsillar exudate, tender anterior cervical lymph node. We call it the jugular-digastric nodes will be tender. Some will be having bad breath or halitosis. The red flags here are sometimes this patient may have airway difficulties or noisy breathing or drilling of saliva because they cannot swallow. They cannot even open the mouth or close the mouth, or inability to swallow, structurismus, or neck swelling, severe unilateral throat pain. They can be toxic in appearance when they present. This is when you look into the throat, you see the two tonsils are enlarged, hyperemic, with tonsillar exudate. In fact, the whole oropharynx has been affected. They can present with severe pain, and you need to do something. What do you need? What are you supposed to do? Mostly, the supportive care is analgesic, warm saline gargling. You can give IV fluid, and the patient, and you admit the patient for a rest. After that, because they cannot swallow, you follow them up with parenteral antibiotics, especially normally we start with ceftriaxone or IV augmentin with metronidazole. But if they present at the level where they can still take oral, this other alternative, penicillin V, amoxicillin, or azithromycin or erythromycin with metronidazole, you can start with that to see whether you can control the condition. The indication for referral in acute tonsillitis is when you suspect abscess or airway compromise, or there's no improvement after 48 to 72 hours of treatment, or when the tonsillitis is recurring, you need to refer for definitive care. Epiglottitis is also another emergency that patients usually present with present to the general practitioners with. It is actually acute inflammation of the epiglottis, and causes are classically bacteria, which includes Haemophilus influenza, others are strep and staph aureus. They are commonly in unvaccinated children and adults. The clinical features are sudden onset of high fever, severe odonophagia, drooling, and muffled voice or inspiratory stridor. The critical role here is that when you suspect epiglottitis, don't examine the throat, because examining it will trigger complete airway obstruction and the patient can just die in your hands. Avoid examining the throat when clinically you suspect epiglottitis. And normally the diagnosis is usually clinical, but in a place where you have X-ray, when you do it, you see that the epiglottis is thickened like the tongue. That's why they call it tongue sign. That's thickened epiglottis, which is called the tongue sign. When you see it on this other side, you see how the normal epiglottis look. On this side, the yellow side that is burning with fire, the yellow where there is yellow color, that's the edema, and it appears like somebody that is thumbing up for something. So that is what you see on X-ray. And the diagnosis, I have said, mainly clinical. However, lateral neck X-ray shows thumb sign. Definitive laryngoscopy, this is not the place for general practitioner. In centers where the treatment is not helping and they want to get the definitive diagnosis, this one will involve the ENT and the anesthetic. That's definitive laryngoscopy. And as I've said earlier, when you suspect epiglottitis as a general practitioner and the basic treatment, the antibiotics, the steroid, and all these things are not working for you, and the patient can afford it, refer immediately. And the immediate management is the airway first. Airway takes the priority because you know the position of the epiglottis. It covers the airway when you want to swallow something, and when it is swallowed, especially if it's in a child, that the rema glottis is very, very small, there will be no place for the child to breathe. So you need to secure airway by either intubation or tracheostomy. Then oxygen therapy is very important. You need to keep the patient calm. Don't use tongue depressor or wooden spatula to check the throat. Keep the patient calm, high flow oxygen, and IV fluid, antibiotics to hydrate this patient and control the infection. IV steroid and NSAID can also be helpful because it will reduce the airway edema and allow patient to maximize the little space he or she has to breathe. Then in laryngotrachea trauma, sometimes blown injury, you see the neck swollen with crepitus, and the patient will be complaining of throat pain, hemoptysis, difficulty breathing, stridor, and all this. These are usually caused by road traffic accident, hijab accident. When I started work here initially, it used to be a common thing. People will tie hijab, go to where they grind corn, and the engine will just trap the edge of the hijab. Before they know it, it will roll them and strangulate them. They usually present with this hijab accident. It is a blown neck trauma. Some of them don't even get to the hospital alive. I had to actually contact some people to do some preaching on it, and it seems now the rate at which they present here is less. And penetrating injuries too can cause it, like livestock, gunshot, and iatrogenic. That's during intubation, they may perforate the airway and they will present with what looks like, they will present with laryngotrachea trauma. The clinical features are hoarseness or voice change, stridor and noisy breathing, dyspnea, respiratory distress, neck swelling, bruising or hematoma, subcutaneous emphysema, that's what gives rise to crepitus, and hemoptysis, pain on speaking or swallowing. The critical warning here is that symptoms in this patient, initially, they may present as if they smile, they'll talk to you, you will see some little alteration in the voice. But this kind of patient, if you don't admit them and monitor them closely or refer appropriately, they can deteriorate rapidly and die in your hands if you don't refer. So don't delay their intervention and their referral and intervention. The management is immediate. Management is the airway. The airway is always a priority. Give high flow oxygen, call ENT, anesthetic urgently, and prepare for control intubation or surgical airway like tracheostomy and cricothyrotomy. Breathing, very important. Monitor respiratory effort and oxygen saturation. Circulation, if there is bleeding, you need to control the bleeding from the site of the injury and establish IV access for fluid, blood, and medication. Additional step is to immobilize cervical spine and keep patient on nail purpose because this blunt trauma to the knee, the cervical spine is part of the structures that can be injured. So you need to be careful the way you handle this patient. Investigation, the gold standard is actually CT scan, but most general practitioners don't have them in their facility. In Taraba State, we don't even have them in our facilities. So what we manage here is X-ray of the soft tissue, AP and lateral, and that only gives us an idea of the kind of laryngotracheal distortion that this patient has so that we can take decision. What we usually do is to do neck exploration. But in primary healthcare, the main thing is to make sure that you know that this patient is at risk and you are supposed to refer them as soon as possible. Encourage them to move to where there are specialists so that they can get treatment. And the indication for the referral includes a strident, noisy difficulty in breathing, change in voice, subcutaneous emphysema. If you palpate it, you hear crepitus on the neck, swollen neck, you palpate, you hear crepitus all over the neck. Sometimes they present with crepitus even down to the chest and even to the face. We've had patients like that. So you need to refer them as soon as possible so that they can get the right intervention. Deep neck space infection. The neck is small, but it may surprise you to know that it has a lot of spaces and a lot of structures there, and infections can affect any of them. Some of the potential spaces in the neck that can harbor infection and abscesses are retropharyngeal space, dental space, prevertebral space, submandibular space, suprasternal space of bone, and anterior visceral space, just to mention but a few. And this serious infection, the common cause are actually untreated tonsillitis or pharyngitis. Dental infections are very common source of infection and abscesses in these spaces, especially in this our environment. Trauma or foreign body in the throat or spread from sinuses or ear infections can also affect some of these deep neck spaces. And the symptoms are usually severe sore throat, fever, painful swallowing, discomfort in swallowing, neck pain or swelling, voice changes, and hot potatoes voices. Signs include trismus, that difficulties opening the mouth. In some spaces, patients can even open their mouth, and neck swelling, deviation of uvula like in peritonsillar abscess, drooling of saliva, and reduced neck movement. The red flags is when there is airway compromise, you have to refer this patient. Drooling or inability to swallow, or when these patients have severe trismus or toxic appearance, neck swelling that is increasing, and all this, we need to refer early so that they can get intervention. Assessment at the general practitioner setting, as mentioned, airway remains the priority in ENT. So we need to check the vital signs for fever and tachycardia. We need to inspect oral cavity if it is safe in this situation. Remember what I say in case of epiglottitis, and palpate neck gently. History of dental infection, recent sore throat, and throat instrumentation of foreign body is very, very important so that you know what is responsible for the infection of the potential spaces of the neck and even abscesses. The immediate management includes you keep the patient sitting upright if the patient is conscious, give oxygen if needed. This is started, right? I just I'm almost okay. So sitting upright, give oxygen if needed, secure IV access if possible, and start broad spectrum antibiotics if available. Then you refer immediately. Sitting upright, because if you like somebody that has that airway is at risk, if you lie these patients flat, the tongue will fall back and completely block the airway. That's why we keep on emphasizing, if the patient is conscious, you need to sit him upright. Then you commence the resuscitation. The supportive care includes analgesic, IV fluid, avoid unnecessary throat manipulation. Very, very important. And complication of deep neck infection, airway obstruction, sepsis, mediastinitis, because some of these space extend into the chest, and mediastinitis is actually a deadly state of deadly complication of this disease. So it's something that we won't wish any of our patients to go into it. And internal jugular vein thrombosis, indication for referral if you suspect it, it is good to refer. And presence of any of the red flags of mentioned, and failure of simple tonsillitis treatment or neck swelling with fever, very important. And I decided to take the foreign bodies of the ear, nose, and throat together. These are presence of foreign objects in the ear, nose, or throat, common in children and people that are mentally disordered. There can be accidental in normal adults as well. And the common objects that we see at the are the beads, the seeds, the nut, the cotton wool, paper, bottom batteries as emergency, insects, bones, that's fish or chicken bones, and in the throat. All these are things, some of the foreign bodies that can lodge in the ear, nose, and throat. And the clinical presentation, if it is in the ear, you can present with ear pain, hearing loss, discharge, which is maybe foul smelling if long-standing, and tinnitus if insect. And in the nose, unilateral nasal discharge is foreign body until proven otherwise, and nasal obstruction, epistaxis, and irritation. If it is throat and airway, they may present with history of sudden choking, coughing, drooling, dysphagia or dysphagia, noisy difficulty in breathing, and respiratory distress. The red flags is airway compromise, stridor, and severe distress. Suspected aspiration, button battery in the ear, nose, or throat, because this battery, when it starts leaking, it has a tendency to destroy the surrounding tissue of where it lodged. So if it is button battery that is lodged in any of the sites, it's an emergency and needs to be referred immediately. Sharp objects like bones needs to be taken care of immediately because it will perforate wherever it is lodging, and bleeding and severe pain are some of the things. This is some of them. Right. I'm on the last slide. Okay. So these are some of the basic things that we need to have as a general practitioner so that we can save the life of this individual with foreign body impaction. And the decision for which one to use is actually very important. And if you don't have them and you don't have what it takes, don't use the wrong instrument for the wrong case, because you may end up compounding the outcome of the treatment of such patient. Then the management at the general practitioner setting, first, especially the airway access, history of the object that is lodged, the time and the symptom. Inspect with good light. Light source, very important if you want to assist this patient. Avoid repeated blind attempts and assess cooperation, especially in children. The patient has to cooperate for you to do something useful. If it is ear foreign body, remove if visible and grabbable. Use forceps, suction, if you can use it. If it is insect, you need to immobilize with oil before removal. Then just put drops of oil in the ear to suffocate the insect before you remove it. And if it is difficult for you to remove it, or it is deep, or you've had an unsuccessful attempt, just refer immediately. If you don't have the right instrument, don't even attempt, because you may compound the problem. We've had situations where a foreign body was pushed into the middle ear that will have to do a major surgery to remove it. So if you don't have the right instrument, don't even attempt to do it. For nasal foreign body, positive pressure, that's parents' kiss techniques. Some parents use their mouth to suck out things from the baby's nose. Sometimes by so doing, they can suck out the foreign body. Instrument removal if the foreign body is visible. These basic things that I've shown in the table before this slide, they are things that you can actually select appropriately and use. Urgent referral if it is button battery, because as I said, if the battery starts leaking, it has the tendency to destroy all the surrounding structures, and that will lead to a serious complication. And it is good here to know that foreign body in the nose is a serious ENT emergency and needs to be removed immediately. Because if you allow it to fall down the throat, three things will happen. One is that the person can bring it out through the mouth. And the second one is that it can be swallowed through the esophagus. The last and more deadly is that it can enter the airway. And if it enters the airway and get impacted there, it's possible that that patient may not get to the hospital alive. That is where we don't want to sleep over a foreign body in the nasal cavity. But in the ear, if it is not battery, I think it is not really an emergency. Though the patients may be anxious, but it is not really an emergency. If it is not a battery or insect or vegetative foreign body, especially in the battery. If it is not that one, the other one, you can sleep over it and do it when you have the right thing. If you don't have, you can refer. But if it is in the nose, if you can't do it, it is good to refer immediately. Because when you allow them go, people in the chemist can try and push it down. And as I've mentioned, any of the three can happen. One of them can actually take the life of this patient. Then for throat and airway foreign body, if choking, institute basic life support like the Himmler's maneuver, you grab the patient from behind and exert pressure that will transmit into the chest, and the patient may actually cough out if the patient is stable. And you ensure urgent referral for removal, and do not attempt blind sweep, blind finger sweep as our mothers and old people used to do, because that may actually compound the problem. Special situation, as I've mentioned, button batteries causes rapid tissue necrosis. Organic materials, beans or seeds swell when they are allowed to be impacted, especially in the larynx because of their contact with secretion, and that worsens obstruction. But because of that, when you have this kind of category of foreign body, if you don't have what it takes to remove them, it is good to refer. An indication for referral in foreign body in general is when you have failed removal attempt, uncooperative child, deep or sharp object, any airway involvement, and button battery case. The general practitioner pair here is that you need to know that any unilateral foul smelling nasal discharge is foreign body until proven otherwise. Button battery needs is an emergency and it needs immediate attention. First attempt is the best chance, so be prepared to keep the child calm and immobilized. When in doubt of what you can offer, please refer these patients early. This is just a small picture of if you see how this insect is just in the external auditory canal of this child enjoying himself, but the child will not sleep. So in this case, this is a situation where I say you need to put olive oil, canning oil that is available, or something that will suffocate the insect, then so that the patient can be calm. At that point, it is no longer an emergency. They can come to where they can be removed safely. So in conclusion, I would say early recognition, safe life and function. Airway is always a priority in ear, nose, and throat emergencies. Avoid unnecessary manipulation, because some of this manipulation can compound the patient's situation. Timely referral to ENT improves outcome. Thank you so much for listening, and these are my references.
Thank you very, very much, sir. You have done a very, very exhaustive job in dealing with ENT emergencies in general outpatient care. We have some questions which we'd like to take, sir. First of all, there are 3 questions so far. First of all, excuse me. So first of all, pregnancy is a risk factor for epistaxis. Are there any preventive measures? The second question is, epistaxis is a complication of Lassa fever infection. What are the management principles to minimize the spread of the disease? And the third question is, please, what is the clarification or explanation of the deviation of the mode of treatment for epistaxis? In the past, we said tilt the head backwards and apply ice. Now we say apply ice to the forehead. Now we say tilt the head forward. What has changed? And that's from Dr. Tsunga. Please, you may answer, sir.
Okay. The first one is okay, here's the first question. Okay, the first one has to do with pregnancy. Right? So pregnancy is what? So pregnancy is the principles of factor. Pregnancy is there any preventive measure?
First question. Pregnancy is a risk factor for epistaxis. Are there any preventive measures?
Okay. Well, thank you very much for your question. Pregnancy is actually a risk factor for epistaxis. And as we all know, pregnancy is associated with physiological changes in the body, and that also involves the nasal cavity. And some of them are actually predisposed to epistaxis. The main thing, there's no definitive thing that will say a pregnant woman should not do to prevent epistaxis, because it is actually a systemic thing. The main thing is that the basic precautionary measures like picking of the nose, they should be encouraged not to pick their nose frequently. And also the aspect of if they have rhinitis, that's rhinitis or sinusitis, they should, or if they have catarrh, they should look for treatment so that it can be treated properly, so that it will not add to the risk that they are already having from the pregnancy. I think these are some of the basic things that they need to do. Because, and sometimes, if the epistaxis is persisting, like one that we've had in one of our colleagues here, and the pregnancy is almost at term, the best thing to do is to deliver the baby. Because the experience we've had then, which I know some of my colleagues here are involved. Pregnancy was almost at term. She was bleeding from the posterior side, despite all manipulations, packing, drugs. That time, some of these anti-hemorrhagic drugs that we use are not even available here. They have to go to Yola to get them. Despite all that, the epistaxis was not stopping. I think we entered theater twice, and the final thing, the option was to deliver the baby via CS. And when that was done, with the little we offer, she got out of it. So these are the things that can be done. But if the pregnancy is not at hand, the precautionary measure is as I've said, avoid nose pricking, avoid anticoagulant, avoid if the patient is hypertensive, it is good to make sure that the blood pressure is under control in pregnancy. And if patient is on any drug that predisposes them to that, and if they have upper respiratory tract infection, it should be treated properly and as early as possible to avoid additional effect of these conditions to the risk that a pregnant woman already has. Thank you very much. for that one. The second one is
Thank you, sir. The second question is, epistaxis is a complication of Lassa fever infection. What are the principles of management to minimize the spread of the disease? I'll take it again. Epistaxis is a complication of Lassa fever infection. What are the management principles to minimize the spread of the disease?
okay. As I've mentioned, the systemic causes of epistaxis, viral hemorrhagic disease is actually one of them. And the basic principle of management of epistaxis remain the same. But the way to prevent Lassa fever is what we all know. As we here were in the Lassa endemic area, and we know these things has season. Like our own here, I don't think there's specific season, but there are times that it peaks. So all the precautionary measures, any patient, any suspected case, we need to actually protect ourselves and also educate the people to avoid doing things that will predispose them to the disease, so that they don't come down with epistaxis. We actually tell them that's the eating of the rabbits, the rabbit we've been emphasizing on, and protecting ourselves, because any patient that comes to the hospital, especially with fever, epistaxis and other things, they are suspects. So we need to use our protective gadgets to make sure that we don't spread the disease. And even at family level, we need to tell them that this is what they need to do to avoid this disease, because it is one of the causes of bleeding from the nose. I think other precautionary measures that we've been carrying out in the hospital should stand at this, and the education of our patients to prevent the spread of Lassa fever is what we should continue to ponder on, so that the societies, our patients, will not come down with Lassa fever and will come to us with epistaxis. I think that's really to have to say on this.
Thank you very much, sir. The other question of the explanation in the different modes of treatment for epistaxis. In the past, tilt the head backwards and apply ice to the forehead. Now we say tilt the head forward. So Dr. Danjuma is asking what has changed.
The emphasis there is that if you tilt the head backward, there is a very high tendency of the blood going backward into the oropharynx. And when blood goes into the oropharynx, three things happen. Some of them will be patient can spit out, some will be swallowed, and some will go into the airway. And the one, if it is much, they can actually suffocate the patient. And if the patient is swallowing the blood, you won't be able to quantify the blood loss. So the stand now is that the patient sits upright, leaned forward, so that anything that is coming out from the nose, especially if it is in the anterior, you will collect it and give the patient a kidney dish to collect them, so that you'll be able to quantify the amount of blood loss in your presence. And anyone that enters the mouth, let him or her species out, so that you'll be able to quantify and prevent blood from entering the airway or being swallowed. I think that is the right thing to do logically, because if you tilt the head backward, as I said, the pool of blood gorging out would be going down into the oropharynx and into the airway, and that may actually be too dangerous for the patient. And with that one too, you won't be able to quantify the amount of blood the patient is losing at that particular time. I think that is what I can say on this one.
Thank you very much, sir. And our last question today, please, the attempt to remove everybody
from the
ear, the tympanic membrane will be ruptured. So the person is asking that in case someone attempts to remove everybody from the ear and the tympanic membrane is ruptured, what does one do, or how does one prevent? That's not that question.
How does one prevent?
The question is, thank you for your presentation. Is the attempt to remove foreign body, the tympanic membrane may be ruptured? That's the question. So I think it's asking probably how to avoid it or what to do in case it happens.
Okay. As I've mentioned earlier in the presentation, if there is a foreign body in the ear, it depends on the type of foreign body and what you have to handle it. And as I said, if you don't have the right instrument, it is not good to even start it. But peradventure, you use something and the tympanic membrane got ruptured. What you do is that if you are able to remove the foreign body and observe rupture of the tympanic membrane, what is expected of you to do is that you don't even tolerate the blood that is coming from there. If blood is pouring outside, you can clean it, but put a little gauze to stop the blood from pouring outside. Let the cloth remain there, because normally what is done is that the cloth will form a template for the tympanic membrane healing, and don't allow water to enter the ear. What you need is that definitely there will be pain. You give antibiotics and analgesic to take care of pain, and you don't even tolerate the clot that is right inside near the other parts of the tympanic membrane. Allow it to clot there, dry there, and don't allow water to enter there. After some time, when the healing has taken place, the clot will come out by itself, because the external auditory canal has a way of cleaning of itself. The mucosa moves on its own. So by so doing, you've been able to sort it, and the ear may not even discharge if you just apply this principle when it happened. But in a situation where in attempt to remove it, the tympanic membrane got ruptured, and you also push the foreign body into the middle ear. When the foreign body is pushed into the middle ear, it is actually very difficult to remove it through the external auditory canal again. We've had incidents like that somebody, on attempting to remove foreign body from the external auditory canal, push it through the tympanic membrane into the middle ear. In that case, you still not allow water to enter that ear. If there are clots there, you can leave it and send it to where there are ENT specialists. What we do is that we go through the back of the ear. We call it post-oral incision. We make an incision behind the ear here, right down to the bone, and lift the pinna up and follow it to where the tympanic membrane is. At that level, you'll be able to see the foreign body, pick it out from the middle ear, and return the pinna back and suture it. What then you ensure that the ear is kept dry. Water shouldn't enter there. As I've said, you put Vaseline in your palm, cut roll a piece of cotton wool and rub the Vaseline around it. It will form like a leather around it. You continue to cover that ear with it whenever you want to bath. And when you are entering rain, try to use umbrella. After bathing, you can remove the cotton wool and throw it. If you are entering rain, you use umbrella. It depends on the extent of the rupture, whether a tank is missing or not. If you keep it dry with some cloths there, it's likely that that perforation or rupture may heal.
Thank you. Yes, thank you very much, sir. Even though we said that was the last question, yes, our CME chairman has asked the question: what's the difference between tracheostomy and a surgical airway? The question is, what's the difference between tracheostomy and surgical airway?
Okay, surgical airway is generally to secure an alternative airway when the normal airway is obstructed. And the alternative can be tracheostomy is actually one of them. Tracheotomy is actually another one. And cricothyrotomy is another one. So all these are surgical airway that one can actually offer a patient that has upper airway obstruction. So in summary, tracheostomy is one of the surgical airway that you can offer to patients.
All right, thank you very much, sir. At this point, we've come to the end of the presentation for today. Please, I'd like to remind us all to remember to fill the attendance form. It's a link in the chat, which has also been repasted again. The Nma Taraba Cme continues tomorrow morning with the AGM, which will be addressing burnout, and it will be by 9 a.m. The Zoom link remains the same, so you can please connect, take part of it, fill that. I would like to say, Chairman, sir, would you like to say anything, sir?
You see with us, he has left.
Okay, maybe there's...
Sorry.
Okay,
you mean
sir,
NMA chairman or CME chairman?
It's the same chairman that's on the call, sir. So you're representing NMA chairman.
Okay, thank you. Good evening, everybody. Want to use the opportunity to thank the presenters who took their time to enlighten us and educate us on some common, elements that we come across every now and then in our practices. Thank you for everyone that have joined today. I can see that the number have increased. Yesterday we had maximum of about 30, 31 or thereabout. Today I can see up to 40 something. So it's a good improvement. And I hope during the AGM together tomorrow and the team lecture that is going to be taken, we expect more people to join. On behalf of the NMA chairman, I want to thank everybody for finding time to be with us this evening for this CME. Please kindly fill the attendance form if you want to get a CME point certificate. Otherwise, if your name is not on the attendance, don't come after this CME period to ask for CME certificate from the secretariat. Please fill it off. Once again, I want to appreciate everybody, and we'll see tomorrow again during the AGM in the doctor's house. The fiscal AGM will take place immediately after the team lecture. Everybody is welcome since we are going to have election and we are going to elect our new officials. We are all welcome, and I wish us a very restful night and a very fruitful weekend ahead. Thank you and bye.
Thank you.
Thank you and well done, Chairman.